Welcome everyone, and thank you for attending this virtual Public Health Day. We are excited to have this opportunity to share the work efforts of local and state public health in ensuring a healthier North Dakota and responding to the COVID-19 pandemic. We have local and state public health officials that will be sharing information regarding the legislative priorities, which include communicable diseases, chronic diseases, and environmental health and safety. We have local representative Erin Arata from Custer District Health that will be providing information regarding the local perspective. And then we have our state experts, Molly Howell, Neil Charvat, and Julie Wagendorf, who will be sharing on the respective legislative priorities. I'm going to turn it over to Mary Korsmo, the Executive Director of the North Dakota Association of City and County Health Officials, for her to make some remarks. And then she can turn it over to Erin, and we will follow in our presentations.
Good morning, everyone, and thank you so much for joining us. We certainly appreciate your dedication during the session and throughout the interim and all that you do to help North Dakota and our citizens. Thanks for taking time right now to listen to our presentation about priorities, and I'm happy to answer any questions that you might have following the presentations. So without further ado, I am going to turn it over to our Custer Health Director, Erin Arata.
Okay. Good morning, everyone. I forgot to unmute myself. I will just bring up my presentation and then we will go ahead and get started. Okay. And as was mentioned, my name is Erin Arata. I am the administrator at Custer Health, which is the health unit in Mandan, North Dakota that serves Mercer, Oliver, Morton, Grant, and Sioux counties. And I will just go through the structure of local public health in North Dakota, what our priorities are, and then what we have been up to in the past year, and then we will answer questions that you may have. First of all, this is a map of North Dakota and then all of the respective local public health units. You can see that our structure for the public health system is quite variable across the state. Most of the western portion of the state is made up of multi-county health districts, and then the eastern part of the state, there are city-county health departments, one city-county health district, single county health departments, and then single county health districts. And now you may be wondering what the difference between a district and a department is, and North Dakota is made up of 28 of these local public health units. Districts are different from city and county government, and so they are administration and personnel are separate from city and county government. They are funded through a mill levy from their counties and cities that are incorporated into their health unit, and they are not to ask for more than 5 mill levies based on the North Dakota Century Code 2335. And these health districts are governed by a board of health made up of representatives from the cities or counties within their health district. Health departments, and North Dakota has 9 departments. They are considered staff of either the city or the county government of which they reside in, and so they are financed through those city or county general funds. The city council, commission, or county commission would then decide if they are going to be the direct supervisor of the health unit or if they are going to appoint a board of health. And local public health funding sources are quite variable. There are local, state, and federal grants, and then there is a state aid allocation that is always included in the Department of Health budget. And for this legislative session, general state aid, we are again asking for $5.25 million and $600,000 of which is earmarked for regional environmental health services that local public health units provide across the state. Here is a further breakdown of our revenue sources. And you can see that most of our funds, about 33%, are made up of local funds. And so those would be from the cities or counties or the mill levy that we are able to access. The next largest portion is from fees that we are able to collect for our services that we provide. 5% would be grants from private foundations. There's 6% provided by tobacco funding. And then we are also able to apply for federal grants. And so 24% of our funding is from that. And then the state aid funding is about 7% of our revenue. And the state aid funding can be used for immunizations, tobacco, maternal and child health, emergency preparedness and response, public health, nurse home visits, community health needs, school health, injury prevention, jail health, administration, and then environmental health. And so you can see that that category, while small, only 7% of our revenue, can be used for various different activities and programs that we are able to provide as health units. Which leads me to the next discussion point. Our minimum core functions are laid out in North Dakota Administrative Code. And as local public health units, we should provide at a minimum these core functions: communicable disease control, chronic disease and injury prevention, environmental health, maternal, child, and family health, and then access to clinical care. And so for communicable diseases, we test and provide other testing for those types of diseases so that we can further prevent them from occurring in our populations. Chronic disease and injury prevention, we have programs and systems in place to address those issues in our population. Environmental health is protecting the public from any environmental hazards that may occur, such as in food and beverage establishments, public health nuisances on private properties, private and public properties, public swimming pools, and then on-site septic systems, just to name a few of the items that we work on. Maternal and child family health, promotion of healthy services and programs, and then access to clinical care. So we collaborate with the larger healthcare system to make sure that there is a continuum of care for all of our public. And now we'll kind of go through the distribution of local health departments by size of population served. So as you all know, North Dakota counties have differences in populations, and our health departments are also differing based on population that we serve. And so the majority of the health units in the state provide services to populations of less than 5,000. And then the rest of the population size, there's a pretty much consistent number of health departments that serve those size of populations. And within our health departments, here's the average number of full-time equivalents by population served. And so you can see the number of full-time equivalents increases based on the population needed. And so for the majority of our health units are serving the less than 5,000 population. So the majority of our health units actually only employ 3 full-time equivalents. And this goes to show that local public health does not employ a large number of people, but we do provide a large number of services, and which shows that our employees are able to do a wide array of things to serve our public. And then the percent of local health departments that perform these different activities. You can see that the majority of the health departments perform maternal and child health activities, as well as environmental health, behavioral health, injury prevention, chronic disease, and then communicable and infectious disease prevention. So the majority of our health departments are providing all of those core services, either directly or by contracting with other health departments. And then syndromic surveillance, which is analyzing data and then using it to prevent further disease, is not done in most of our health departments, but about 22% of our health departments. the percentage of local health departments that provide screenings by population served. And so you can see these screenings are for HIV and AIDS, other sexually transmitted diseases, tuberculosis, cancer screenings, cardiovascular disease screenings, diabetes, high blood pressure, and then BMIs. And the smaller health departments focus more on high blood pressure and BMIs. The larger health departments do more of the communicable disease surveillance and screenings. There's a wide array of who does what, and as you can see, the 10,000 to 20,000 population covers most of these screenings pretty well. And then the percent of local health departments that provide environmental health activities by population served. You can see that the smaller health departments do not necessarily employ environmental health practitioners to provide environmental health services, and therefore those health units typically contract or are in a regional public health network, and then those environmental health services are provided by other neighboring health units. And so we collaborate to make sure that all of our counties and populations served in North Dakota are able to receive these environmental health activities and services because they are important to the safety of our public. Okay, and now I will dive into some of the real-time issues that we were experiencing during the pandemic was continuity of services. When the pandemic started back in March of 2020, we had to quickly figure out what our essential services were to continue providing on top of our pandemic response. And so local public health departments really were the core group to work on pandemic response, and therefore we had to kind of set back some of our services so that we could focus on the pandemic. However, we were able to continue to provide most of our services, which was necessary because they are necessary within our communities, and just not stopping providing them wouldn't have helped anybody. And so we did our best to make sure that we could still continue on with everything that we had done prior to the pandemic. However, it was challenging. And for instance, in Custer Health, we were able to continue serving 290 individuals in our Mandan Good Neighbor Project, which is our harm reduction program. We also continued providing services for low-income first-time moms and their babies through our Nurse Family Partnership Program. And this program is administered jointly with Bismarck-Burley Public Health across the river. And we were able to continue serving 53 mothers and 38 infants throughout 2020. And all of this was virtual. We did not do home visits like we typically would do with this program. We were able to provide them virtually, and virtual visits are not as easy. And so it was exciting to see that most of our mothers continued on with this program because it is necessary in our community. And then we also continued to provide almost all of our other public health programs to as full extent as possible. In Grand Forks Public Health, they were able to submit all of their documentation for public health accreditation, which is very exciting. They submitted that in September 22nd of 2020. And then they also continued on with their restaurant inspections, their on-site septic system inspections, a mosquito control program. They were able to continue their syringe service program in the community. They increased telehealth visits for tuberculosis clients, continued other home visits, Ryan Wright case management, and school consultations. They exceeded a goal for Women's Way enrollment and screenings. They had virtual wellness programs offered to their city and county employees, and then they also convened a Blue Zones community stakeholders meeting, which was made up of focus groups of community stakeholders, and it was basically a community assessment process. And so very important work that continued on even though Grand Forks Public Health was responding fully to the pandemic. And two other health units with some stories to share. So in Cavalier County, they continued to maintain a high rate of vaccination for vaccine preventable diseases. They also worked to address opioid misuse and were able to hold 8 Narcan trainings, and 100 individuals were trained. They continue to address mental and behavioral health issues by hosting monthly task force meetings with their community partners. and they partnered with the local hospital to have a combined approach for tobacco cessation. And then over in Walsh County Health District, they worked with community partners to increase the number of women who initiated and maintained breastfeeding. They distributed over 500 radon kits to the community, and they also continued to provide infant, child, and adult immunizations. Lots of important work that continued on during pandemic response. And now we'll get into the majority of our pandemic response. And right now, the hot topic, of course, is the COVID-19 vaccine administration process. And this graph was current as of the 4th of February, and it shows the number of doses administered by local public health units based on the population size. And you can see the larger the population, the more doses are typically given, more employees within those health units, and therefore they are able to administer more doses more rapidly. And so total as of last Thursday, 38,452 doses administered by local public health alone in the state of North Dakota. Additionally, local public health helped with COVID-19 testing, and they started doing testing, I think, in April of last year, and have continued it on throughout the pandemic. And you can see again that the larger health units did conduct more testing, again, based on the number of employees that they had available. But total as of last Thursday, since the beginning of the pandemic, local public health has done 141,562 tests. And then, as was mentioned by Kelly and Mary at the beginning of the presentation, local public health priorities for 2021-2023 would be continuation of COVID-19 response. We will continue to provide mass vaccinations, COVID-19 testing, and then also assisting with disease investigations, and that would be the contact tracing efforts. Environmental health, particularly on-site wastewater systems, having a unified code across the state is something that local public health and the industry together would like to see happen during this legislative session. Increase in behavioral health services across North Dakota, which will be even more important throughout the pandemic. Continuation of tobacco prevention and education, and then further substance use prevention resources. And then to close out my presentation, just to highlight the importance of public health and why we need to continue to support it in North Dakota. U.S. life expectancy more than doubled over the last 200 years, and this was largely in part due to the efforts of public health. Most people contribute this gain in life expectancy to medical advancements. However, if we look at it, the largest gain in life expectancy occurred between 1880 and 1920, when medical advancements were quite limited. So therefore, these efforts of public health that have helped with life expectancy really are the core of why we are living longer and healthier lives. And these efforts include the control of infectious diseases, more abundant and safer foods, increased sanitation, and then other non-medical social improvements. Our society cannot continue to thrive without continued support of public health efforts. And that is why I thank all of you for joining in today, and I hope that you can see how hard public health has been working through pandemic response and the wide variety of services that we provide to help improve the health of our public and our communities. And now I will take any questions that you may have.
Thank you, Erin. So yes, if you have questions for Erin, please put them in the chat or the Q&A, and we will facilitate those questions and answers. While you're taking the time to put in your questions, I do want to make reference to the public health fact sheet that was attached to your meeting invite. It does reference those core foundational areas of public health core services that Erin had mentioned, and it describes a little bit more about the activities involved in each one of those core services. I do need to correct, though, those core services have not been adopted into North Dakota Administrative Code yet. So just keep that in mind for those that are wanting to address those efforts. I see no questions for Erin, so I think we'll move on to Molly, and Molly will talk about communicable disease.
Thanks, Kelly, and good afternoon, everyone, and thanks for joining today. I'm going to be talking about efforts from disease control and mostly focusing on the past couple of years. And so disease control, just for your awareness, is made up of a number of different divisions, including sexually transmitted diseases and bloodborne pathogens, and that would include hepatitis, HIV, and then also our infectious disease and epidemiology division, which focuses quite a bit on vector-borne diseases like West Nile virus, and also enteric diseases like Salmonella and E. coli. Our immunization division, for which I'm the director, field services, which are our epidemiologists that are located out in the field, most of them placed with local public health departments, and they really do some of our core functions for investigating various mandatory reportable conditions. And then, of course, this year we have stood up a COVID-19 division within disease control. And so North Dakota does have a number of what we call mandatory reportable conditions, everything from A to Z, so acute flaccid myelitis to Zika virus. And so these are different diseases that when tested or diagnosed have to be reported to the North Dakota Department of Health within 1 business day. The vast majority of providers are electronically reporting to Disease Control's electronic surveillance system, also known as MAVEN. And so I was just going to go through each division within disease control and talk about some highlights from the past year. Erin had mentioned syringe service programs, and so I did want to mention that we did add 2 additional syringe service programs. Our division does approve those programs, and they have been really successful. In 2019, 628 people were served by syringe service programs throughout the state, and 190 were referred to substance abuse treatment centers. And so this has been a successful program. But I also want to mention, because of COVID, for all of our divisions, it has brought some challenges, especially with people not wanting to go into the doctor's office. And so HIV testing and counseling referral sites saw a decline of about 52% in people coming in for that service in 2019. And then hepatitis C testing was down 64% in 2020 from 2019. And so we are concerned that there are some infections going on out there that are going undetected due to reduced testing. In our infectious disease and epidemiology division, this past year they did investigate 17 state and multi-state and enteric disease outbreaks, and that was in the first 3 quarters of 2020. And so these are outbreaks that you may see on the news, like Salmonella or E. coli, associated with different food products or different animals. And so the state does play a role in investigating those and helping our federal partners identify sources for various outbreaks through our investigations. Also, we did actually earlier this year have a case of infant botulism, which was the first case that we've had reported since 2018. And so what we do as a division is we connect the infant's healthcare provider with national botulism experts that are able to provide timely treatment for infants with botulism. And this infant was able to recover from botulism, which is a very severe disease, especially for young infants. Also of note, I just wanted to point out that we were a part of a national Salmonella outbreak linked to hedgehogs. And so Salmonella is an enteric illness, and we were able to determine from laboratory testing and epidemiology that a hedgehog in a home of a North Dakota individual was the source of an individual's illness related to Salmonella, and determined it was related to a national outbreak. even through COVID, we are still continuing our influenza surveillance. We have definitely seen less cases of flu reported this flu season compared to last flu season. We don't necessarily know why. It could be somewhat masking. It could be what they call viral interference. So it's possible that with COVID going on, it makes it more difficult for flu to go on. And it could just be that we're going to see a later flu season this year, and we have had years where influenza peaked later, even after March. And so I think we'll have to wait and see, but we are continuing to conduct influenza surveillance this flu season. For our immunization division, some highlights. This past flu season, the 2020-21 flu season, almost 7,000 more doses administered for flu vaccine compared to the previous season, and that's based on data reported to the North Dakota Immunization Information System. And so even with responding to COVID and preparing for COVID vaccine, healthcare providers and local public health across the state maintained or increased the number of flu doses administered this past flu season. And then according to national data, North Dakota was ranked second in the nation for our HPV human papillomavirus rates in teens, ages 13 to 17. And so the CDC is reporting that in North Dakota, 9 out of every 10 teenagers are starting the HPV vaccination series. And this really is a cancer preventing vaccine. It prevents cervical cancer and oropharyngeal cancer. And so we're really happy to see North Dakota's HPV rates continuing to increase. As you can imagine, for disease control, COVID-19 has kept us rather busy over this past year. We've brought on a number of staff and also contract staff to assist with case investigation and contact tracing. At our peak, we had 479 contact tracers assisting us with COVID-19 cases and contacts. Through yesterday, we've investigated 98,184 cases and their associated contacts. Over 95% of cases right now are initiated within 1 day of notification to disease control that they tested positive. And you can see in the picture on the right how quickly we've been following up with their contacts as well. And so in December, 97% of contacts were interviewed within 24 hours. It was lower in November, of course, where we had our peak of COVID-19 cases. Additionally, we have a team that's following up with all long-term cares when they have a case of COVID and providing guidance on infection control and any other assistance the long-term care facility may need to prevent further spread for COVID-19. And then, of course, vaccination. Right now, we're very busy making sure we're getting vaccine out as quickly as possible. North Dakota has been consistently at the top of the nation in terms of the percent of doses administered out of those received, and a lot of that is due to local public health efforts in vaccinating and other healthcare providers. We have over 400 different provider sites enrolled to administer COVID-19 vaccine. And through yesterday, 137,470 doses have already been administered in North Dakota. And we're hopeful that through vaccination, we can get back to a new normal post-COVID-19. And I will turn it back to you, Kelly.
Thank you, Molly. Any questions for Molly, please write them in the chat and we will facilitate those. Seeing none yet, so we'll turn it over to Neil Shervat.
Good afternoon, everybody, and pleasure to be with you today. Thank you for having me. My name is Neil Shervat. I am Director of the Tobacco Prevention and Control Program at the North Dakota Department of Health. North Dakota Department of Health Tobacco Prevention and Control Program faces challenges relating to COVID-19 epidemic. These same challenges also result in opportunities for the Tobacco Prevention and Control Program to realize efficiencies and learn ways to enhance tobacco cessation efforts to help all tobacco users, including people affected by lung issues like COVID-19. Challenges the program faced are familiar to many dealing with COVID-19 issues, such as remote work and staffing issues. The Tobacco Prevention and Control Program team quickly learned how to work from home, yet continue to function as a team. Every Department of Health program assisted in COVID-19 response efforts, including the Tobacco Prevention and Control Program. Program staff assisted with hotline and school response efforts. This helped the Tobacco Prevention and Control Program to understand the strain being put on our program grantees. The program exercised patience and understanding regarding contract requirements. Healthcare cessation staff have been unable to dedicate their time solely to tobacco treatment due to reassignment or reduced hours. Cessation grantees' goals of developing or enhancing electronic health records are delayed with the competing priorities of the COVID-19 pandemic. 2 annual grantee-hosted in-state conferences have been postponed until the spring or transitioned to a virtual format. Smoking is a risk factor for more severe COVID-19 symptoms. COVID-19 causes a rise in hospitalizations, adding to hospital workloads, and drew tobacco treatment specialists away from cessation work to direct patient care. The Department of Health system partners responded immediately to this public health crisis by modifying their workflows to include COVID-19 testing, providing nicotine replacement therapy by mail and curbside pickup, and offering telehealth services for tobacco cessation counseling. COVID-19 has exacerbated the health and economic consequences of vaping and cigarette use. Youth and young adults who vape or smoke are more likely to test positive for COVID-19. A recent study addressing the relationship between youth smoking and e-cigarette use and COVID-19. The results of this online national survey of 13 to 24-year-olds found that ever users of e-cigarettes were 5 times more likely to receive a positive COVID-19 diagnosis. Ever dual users of electronic cigarettes and combustible cigarettes were 7 times more likely to receive a positive diagnosis and 4.7 times more likely to have a COVID-19 symptoms. The Tobacco Prevention and Control Program realized that the COVID-19 pandemic could provide an opportunity to determine if tobacco use impacted the risk of being infected by the virus or if it had any detrimental impacts on recovery from the virus. The program took advantage of robust data collection efforts that were required to track the pandemic. Analysis of this non-identified patient data demonstrated potential issues with COVID-19 and infection and recovery efforts for those using tobacco. Smokers are more likely to be hospitalized and have longer hospital stays due to COVID-19. Looking at hospitalization data and comparing smokers and non-smokers who were hospitalized due to COVID-19, smokers with COVID-19 were hospitalized nearly 3 times the rate of non-smokers with COVID-19, and smokers with COVID-19 on average spend an additional day hospitalized than non-smokers with COVID-19. The average estimated COVID-19 inpatient costs per day were $11,000. The Tobacco Prevention and Control Program continues to work addressing smoke-free air concerns. Casinos on American Indian reservations in North Dakota implemented more smoke-free air policies when reopening from COVID-19 related closures. The Tobacco Prevention and Control Program efforts helped lay the groundwork for these efforts, including air quality testing, educational efforts with tribal councils and casino management, and surveys of casinos' employees and patrons. The Tobacco Prevention and Control Program continued to provide tobacco cessation resources during COVID-19 epidemic, such as end-quit cessation services through telephone, web, and healthcare system engagement. The Tobacco Prevention and Control Program is concerned about the effects of COVID-19, especially for those impacted by the negative effects of tobacco use. And that is my contact information. If you have any questions, I'd be happy to address them today. If not, feel free to reach out to me.
Thank you, Neil. Any questions for Neil? Please write them in the chat or the Q&A. All right, we're going to move on to our last presenter, definitely not least, Julie Wagendorf.
Julie, you are muted.
Can you hear me now?
Go ahead.
Thank you. The Division of Food and Lodging is responsible for protecting public health through licensing and inspecting regulated establishments. The division oversees several different program areas, including manufactured foods, retail food service and food stores, school and childcare food service kitchens, mobile home parks, campgrounds, lodging establishments, assisted living facilities, and certain personal care services. Additionally, under a contract with the Board of Funeral Services, the division conducts inspections of funeral homes and crematoriums. We are dedicated to ensuring safe and sanitary establishments for consumers of these services in North Dakota through education and inspection of licensed facilities. The division is made up of 10 employees, including 7 field inspectors assigned regionally throughout the state. Each year, our division licenses and inspects over 3,500 establishments. We advance our mission by collaborating, networking, and training with tribal and local health units, the industry, and other state and federal agencies. We promote integrated and uniform regulatory programs managed under local control when feasible. In keeping with our mission, regulatory authority is delegated to 9 local district and city public health units located throughout the state. These 9 health units operate environmental health programs which license and inspect establishments located within local jurisdictions in addition to local ordinances. The building blocks of our foundation are talented and dedicated employees, all with unique skill sets and areas of expertise. The environmental health practitioners, or EHPs, who conduct inspections at the local and state level are required to be licensed in North Dakota. There are approximately 80 licensed EHPs practicing in North Dakota. The North Dakota Environmental Health Association promotes a professional network for licensed EHPs working in North Dakota by providing opportunities for mutual exchange of knowledge and experience between members. NDEHA works in partnership with the On-Site Wastewater Technical Review Board, hosts an annual education conference, and promotes outreach and partnerships with the regulated industry. Most local public health units have limited resources to acquire electronic license and inspection systems and sustain support for information technology. Food and Lodging administers a statewide license and inspection data management system, which is offered at a zero-based cost to local regulatory programs under MOU with the state. The integration between state and local governments in North Dakota is improving due to the availability of the software. The information management system provides a data bridge for the Department of Health and local public health agencies to provide data sharing and reporting. Digital online inspection reports are available to the public. The system provides time and cost savings and improves uniformity of inspections, tracks performance measures, and improves data integrity through quality assurance procedures. During the pandemic, the division led a successful transition to a new computer support vendor through the RFP process. The previous vendor stopped services and no longer offered support for the software. And we also coordinated a necessary upgrade to the SQL server supporting the state system, all while continuing to support the division and the 4 local public health units who currently use the system, as well as planning and onboarding 3 additional local public health units. By 2021, 7 of the 9 health units under MOU will be live using the statewide system, which means of the nearly 5,000 food establishments licensed in the state, almost 70% will be managed by one system. Process improvement and performance measures are tracked using the Food Safety Data Dashboard. Tracking operational costs, completed inspections, complaint investigations, and measuring the rate of compliance with state laws and regulations. The ability to generate a statewide customer illness complaint reporting and tracking system is necessary to have effective surveillance data to track illness complaints, clusters of foodborne illness, and provide early identification and rapid response to stop the spread of foodborne outbreaks. The division serves as the Food and Drug Administration's liaison on issues related to manufactured food and distribution of interstate commerce. During 2020, foodborne outbreaks investigated by the department and local partners included 3 nationwide outbreaks. In May through August, cyclospora associated with mixed bag lettuce infected more than 1,000 people in 34 states. North Dakota had 6 cases. Salmonella Newport in onions occurred in July 2020, infecting more than 1,000 people in 48 states, where North Dakota had 9 of those cases reported. And E. coli 0157H7 associated with consuming leafy greens such as romaine and spinach reported cases in over 40 cases in 19 states, North Dakota with 4 of those cases. The past year has been trying and difficult for everyone. On behalf of the department, we express our appreciation and gratitude for partnerships with local, state, and tribal public health partners, stakeholders, and industry leaders throughout the pandemic to help keep workers safe, customers and consumers safe, and return consumer confidence. Just to name a few, collaborative partners, the North Dakota Department of Commerce led industry outreach and work groups regarding mitigation strategies, helped develop and educate about Smart Restart, and coordinated economic assistance. The Great North Dakota Chamber, NDSU Public Health, and NDSU School of Manufacturing led webinars and trainings provided for the food industry, and the North Dakota Safety Council and OSHA helping with manning our COVID-19 hotline, responding to calls and referrals, and offering virtual trainings and webinars. The list goes on. We are proud to be part of this network, and we appreciate everyone's effort in working as one through this challenging time. COVID workplace assessments for businesses are used to target high-risk areas in their operation where protocols and additional controls may be necessary to mitigate spread of COVID and prevent closures or reductions in operations. Over 1,000 virtual consultations just by food and lodging. I don't have data available for the local public health units. Over 1,000 virtual consultations were conducted in April and May. By June, field inspections had resumed, maintaining continuity of government services and statutory obligations. Food and lodging worked closely with local public health units and contact tracers to assist licensed establishments when notified of ongoing spread of COVID at the workplace. This graph shows the number of clusters counted when 3 or more employees were identified through case interviews and contact tracing as having been exposed at the workplace. It is noteworthy that the graph shows the number of COVID clusters identified at licensed establishments starting to decline in October. As Molly noted earlier, it was during that time the caseload in North Dakota grew to the point of maxing out the department's ability to conduct contact tracing. Contact tracers were redirected to assist with case investigations, and cases were asked to self-notify their close contacts. And our contact tracing was resumed in December. This is the same chart depicting clusters by local public health regional response, who responded to 145 clusters and licensed establishments. This chart underscores the value that contact tracing has in surveillance and early detection of outbreaks that leads to rapid response necessary to prevent business closures, reductions in operations, and prevent further spread into the community. The department builds partnerships to help assure that our state has a safe and ample food supply. Success is not possible without the food and agriculture workers from farm to table. Thank you for all you do for your constituents and for your support. I'm happy to answer any questions about our programs.
Thank you, Julie. Again, if you have any questions for any of the presenters, please write them in the Q&A window. While we're waiting for some of the questions to come over, for the legislators on this event, we did set aside some time for you to chat or reach out to your local public health unit administrators so they could provide you a unique perspective of what's happening in their jurisdiction, or if you want to ask specific questions regarding those efforts. The invite that they may have sent has the local information on how you would connect. If not, if you did not receive that, please reach out to your local public health administrator. They have a lot to tell you. So, and thank you for everybody that has attended. I see no questions. So I don't know, Mary or any of the presenters, do you have anything to add? Thank you again for your time.